Well, good afternoon, ladies and gentlemen. My name is Nirav Shah. I'm the director of the State of Maine Center for Disease Control and Prevention. I'm delighted to join everyone this afternoon to provide an update on the entire COVID-19 situation for the state of Maine for today, Wednesday, July 8th, 2020. I'd like to begin today by reporting some sad news from yesterday. Yesterday, the Maine CDC recorded the passing of a man in his 90s from Cumberland County with COVID-19. His passing, which again was recorded yesterday, not today, marks the 110th death of an individual with COVID-19 across the state of Maine. We continue to offer our condolences to all the family, friends, and communities of those in Maine who have lost loved ones during this difficult time. As of this morning, Maine CDC is now reporting 3,460 cases of COVID-19, an increase of 20 cases since yesterday. Of those cases, 3,065 are confirmed and 395 are probable cases. Right now in the state of Maine, there are 22 individuals who are currently in the hospital. 8 of them are in the ICU and 4 of them are on ventilators. As I mentioned a moment ago, sadly, there have been 110 individuals who have passed away with COVID-19. And so far, 2,856 have recovered from the disease. Among our cases are 831 healthcare workers. I'd like to provide a quick update on some of the outbreaks that Maine CDC has most recently been involved in. Let's start with the longstanding outbreak that Maine CDC has just recently closed. Yesterday, we closed our outbreak investigation into the outbreak at Cape Memory Care. Many of you may recall there was a significant outbreak there, totaling well over 80 patients, 85 patients to be exact. Maine CDC yesterday closed that outbreak investigation after having worked with the facility for several weeks to provide not just testing, but also PPE training, as well as PPE itself for the staff at the facility. We'd like to take a moment now to thank our colleagues at Cape Memory Care for their partnership during this very difficult time. Maine CDC is just recently also opened an outbreak investigation into a workplace. This one is at the Pratt & Whitney facility in North Berwick in York County, where thus far, Maine CDC is aware of 6 total cases. Of those 6 cases, 4 are among individuals in the same department. As we do with most workplace investigations, we are touching base with the facility to try to learn more about the nature of their exposures, of who they may have given COVID-19 to, and where potentially those individuals may have gotten it from. As always, as our investigation continues, we'll make sure to keep everyone updated. I'd like to take a second to just step back and think about some of the milestones nationally that we have now seen just in the past few days. Not long ago, 6 months ago, there wasn't even a single confirmed case of COVID-19 in the United States. The first confirmed case in the United States came on January 21st. Within 100 days, under 100 days, that one single case in the United States turned into 1 million cases. 43 days after that, the United States hit its 2 millionth case. And today in the United States, we have unfortunately reached another milestone of 3 million cases nationwide. But in fewer than 6 months, the number of recorded cases has gone from 1 to 3 million nationwide. Unfortunately, as many of you are certainly aware, the acceleration of new cases nationwide continues apace. We are constantly reviewing the data within the state of Maine to detect whether there is any uptick occurring here and as we do in general, to see if those data, not just in Maine, but across the Northeast, are showing similar signs of an uptick such that we may need to take action as well. I'd like to turn now really quickly to a couple of other updates. The first, speaking of milestones, is a brief update on the work that our colleagues at the National Guard are doing to help healthcare workers across the state get fit tested. I've spoken about this work multiple times, but yesterday we reached another milestone there. As of the close of business yesterday, our colleagues at the National Guard had fit tested over 3,000 healthcare workers across the state. To be precise, 3,001 healthcare workers across the state have now been fit tested such that they can utilize N95 masks. Now, when you think about the number of healthcare workers overall and their likelihood of being infected with COVID-19, the fact that now 3,000 more healthcare workers than just as compared to a few months ago can now take advantage of this highly effective piece of personal protective equipment is a milestone that we should all be proud of during this time when so many difficult things are facing us. So I'd like to take a moment not just to thank, but really truly commend the men and women at the National Guard for helping healthcare workers in Maine achieve this 3,000 healthcare worker milestone. Now, in terms of testing, I'd like to provide a couple of updates on where we are. The first is a recap of the testing situation that occurred yesterday. Just within the state of Maine yesterday, based on the 2024 PCR tests that were conducted, yesterday's one-day point positivity rate was 0.79%. This brings our 7-day weighted moving average for PCR positivity rates to 1.28%. This is, speaking of milestones, the first day that our PCR positivity rate has fallen below 1.3%. On a cumulative basis, this means our cumulative PCR positivity rate is now at 3.58%. This is one of the numbers that we pay the most and closest attention to. It's a number that could go up just as easily as it has come down. But this is a number that tells us, even though we are on the right path, we still have more work to do. Specifically, not so much with the positivity rate, but with the overall volume of tests that are being completed. On that score, Maine is still conducting approximately 150 tests for every 100,000 individuals. We still have more to do to expand the overall volume of testing that needs to be done across the state. But in terms of who we are testing and the results that we are seeing, which is partly measured by the positivity rate, there are good signs on the horizon, even though, as I talked about on Monday, we must not use this as an opportunity to celebrate. That positivity rate could go back up just as quickly as it has come back down. And finally, before I turn to our colleagues in the media, just a brief update on our work to distribute PPE across the state. Even though I haven't mentioned that work in quite some time, I think it bears an update very briefly. As by the close of business today, the Public Health Emergency Preparedness Team at Maine CDC will have filled nearly 2,500 orders for PPE from healthcare facilities, emergency management agencies, first responders, and long-term care facilities across the state. To put that number in perspective, that will be, by the end of today, well over 1.8 million pieces of PPE distributed to healthcare providers across the state. To be precise, the number is 1,828,945 pieces of PPE that will have been delivered by the end of today to healthcare providers across the state. So with that, I'd like to now turn to our colleagues in the media, and today's question goes to Patrick Whittle from the AP.
Thank you very much, Dr. Shah. couple of quick things. I believe the emergency ends on is scheduled to end on July 10th, and I'm curious if that's still the schedule that we're on, or if we could hear it, or if there's a possibility it could be extended again. Also, I'm sorry to make you repeat yourself, but while you were giving us the really important statistics about the positivity rate, there was a yellow jacket in my house, and my wife bravely got it out the window. But while I was cowering in fear, I missed the numbers. So, yeah, if you could run those statistics past us one more time, that would be really excellent.
You got it, Patrick. I applaud your honesty. So let me answer your first question first. There is an intention to extend the state of civil emergency that should be done very soon. The second question, just to go over the positivity numbers really quickly, for the 1 day number, based on 2024 PCR tests done, yesterday's point positivity was 0.79%. The 7-day weighted moving average for PCR tests is now 1.28%, and the cumulative PCR positivity rate is 3.58%. All good? All right, we're going to turn to Megan.
Thank you very much.
You bet. We're going to turn to Megan from WMTW next.
Thank you, Dr. Shah. My question is about some of the things that were touched on during the White House coronavirus task force briefing that happened earlier this morning. A lot of the focus was on returning safely back to schools. And, the question becomes, there's three simple questions, but, where we are in terms of, geographic location, who are we talking about, kids, and what activities are we looking at, meaning going back to school. So we have to measure these things. Are there any ideas that you have, or do you have any input on whether or not it is the risk of going back to school is somehow, tempered by, the risk of being home, meaning the American Academy of Pediatrics has said it really is safer for children to go back to school. Where is the greatest risk?
Sure, Megan. I'll start by saying we were familiar with the AAP's guidance. I think they got it right. As I've mentioned during these meetings, our baseline presumption as we think about return to school is that school children should be returning to physical in-class education come the fall. So the goal is how to make that happen in a manner that provides for safety for the children as well as teachers, administrators, and other staff who work in the school. I don't think it's a simple binary question about where is it safer to be, partly because that could change over time. If there happened to be a significant outbreak or a significant spike in the background rate of cases in a particular county, that might change the calculus a little bit. So what we're thinking about as we work with the Department of Education, public health's charge in helping in participating in these conversations, our charge is how to think about not just what the risk might be at any one time, but how it might change. What pieces of data would we need to be looking at on a frequent basis to determine whether on a region by region, county by county level, it's acceptable or permissible or desirable for kids to be in the classroom versus in some sort of modified classroom setting versus back at home. And those could change depending on the contours of the outbreak or the situation in week to week or. So that's the way that we're thinking about it, Megan. It's, again, going into it with the presumption that in-classroom education should be the goal. But what modifications might need to be made, or what might we need to prepare schools to make in the event that the epidemiological situation on the ground took a turn for the worse? So that's what public health's role in this is. Certainly, we are well aware and are taking in mind the various psychosocial benefits to children being in class and in class participating in education. So again, it's really not a yes or no, easy flip a switch on or off. It's really more of a gradient based on what's going on the ground at any one time. I am going to turn toward Lee Nelson at News Center next.
There we go. Thank you, Dr. Shah. Kind of a two-part question regarding out-of-staters. Part one, have we been talking with Massachusetts? Do we know where they are? Do we know how close they are to potentially being able to let folks in without the 14-day quarantine for the pre-tests? And number two, I know you've been hesitant in the past to talk about out-of-staters here in Maine who test positive and adding those numbers in. Is there on the horizon a time when we will start to get that type of information as well, out-of-staters here in Maine and their numbers adding to our numbers?
Sure. So Lee, as to the former question, we've had a number of conversations with our counterparts in other states. This past weekend, I connected with my counterparts in both Massachusetts and Rhode Island to brief them on where things stand in our state versus their state. Just recently, we had a separate conversation as well with Massachusetts. So there's a lot of dialogue between the two states. Our baseline, again, as we undertake this analysis, is at what point is any other state at least as safe as Maine, if not safer? And we look at a number of different criteria as we make that calculus, or as we do that calculus. It's not just a single number, it's a variety of numbers, and it also takes into account qualitative factors, if there's a big outbreak, something of that nature. And right now, as I conveyed, and we have conveyed to both Massachusetts and Rhode Island, they're not quite there yet. Their numbers are trending in a positive direction, but so are our numbers. So they've still got some more catching up to do. We take a look at this on a pretty frequent basis. So if we get to the point where they are squarely within the zone of safety that we would consider acceptable for Maine, then so be it. But I think it's also important for folks to know this is not a one-way ratchet. If another state experiences significant uptick in cases, that might have to go the opposite direction. So definitely not a one-way ratchet, something that we look at very carefully. We do this with one and only one goal in mind, which is to keep people in Maine safe. If folks from another state have a higher likelihood of having COVID-19 than does the average person in Maine, it's going to be a challenge. So our threshold there is very clear. We only are willing to go down this route if someone from another state is at least as safe as they would be if they were from Maine. Which leads me to the second question you asked me. With respect to out-of-state individuals, we ran the numbers not too long ago. There were roughly 100 individuals. I can get you the exact number, but it was roughly 100 who had out-of-state residents who had tested positive for COVID-19 in Maine. As has been the case previously, the majority of those individuals were from New Hampshire and a smaller fraction from Massachusetts. These are folks that get their health care in Maine and then return to their home state. As to the others, what's important to keep in mind is that even though an individual may test positive in Maine as an occasional tourist, we don't know whether they are still here. Many individuals could test positive here and then 24 hours later be back in their home state. But given that of the now 3,400 cases that we've got in the state, maybe about 50 or so are from out-of-staters, we don't see that as a significant fraction of what we're looking at overall. And so we're always evaluating whether, whether we're how we're thinking about this. So to the specific question you raised, might we make these data more available? We may, but with several important caveats, the chief among them being, we don't know when an individual who gets tested positive in Maine returns to their home state. They could be here for a day, they could be here for a month. So our contact tracers, after they've been deemed to be recovered, may not know where they are because that's the nature of travel. So contact tracing is not location tracking. It's who have you been in touch with? How are you feeling? It's not where did you go today? So we always have to keep those facts in mind. With that, I'm going to turn to Patty White over at Maine Public.
Hi, Dr. Shah. I wanted to ask you about PPE. I know the state has worked really hard to acquire and distribute PPE, in particular to hospitals and nursing homes, but I'm hearing from some other healthcare providers that either their PPE supplies are still kind of tenuous or that they're doing fine for now, but if there's a surge, they don't really have a backup supply. And one person I spoke to said that they feel that this could impact the ability to expand testing in the state. So I'm just wondering if that's something that you're concerned about with the goal of expanding testing by the end of the month. Are you worried about having enough PPE supply to be able to do that? And is there anything, is the state able to acquire any more and distribute it more broadly to other healthcare providers?
Sure, Patty. I wouldn't be doing your question justice if I did not take a moment to, as I did way back when we started these briefings, I wouldn't be doing your question justice if I didn't take a second to just read off our PPE inventory. It's been a while since I've done so. So for a bit of sake of old times, I'm going to just kind of provide a snapshot of where all of our PPE inventory is right now, and then answer your question directly, Patty. So with respect to N95s, our current inventory is 370,760 masks. For surgical masks, 3,076,000. For face shields, 162,250. For gloves, 2,635,000. For surgical gowns, 960,000. Coveralls, 22,000. Cloth masks, 458,000. Disposable protective suits, 69,000. Aprons, 1,600. And disinfectant wipes, 25,000. I do that, Patty, to just reemphasize that one of our tasks right now, one of our strategic goals has been not just to furnish PPE out there, but also to continue building up our strategic reserve in the event that we did face a second wave, which is entirely possible. So we have been consciously building up our strategic reserve of PPE while we've simultaneously been filling orders. Are we concerned? The answer is yes. What we've seen in southern states and western states is even though they too had been building up their strategic reserve, when the most recent spike of cases hit, PPE for those states has again become a scarce and precious commodity. So we remain concerned about that, even though we're simultaneously building up our stockpile. One important note, Patty, is that with respect to testing, one of the changes, even you call it an advance, in the way that testing is undertaken is for the preference for swabbing, medically observed self-swabbing. The reason that this is important is that it greatly reduces the amount of PPE that is needed. Previously, when swabbing and testing first came on the scene, an individual, the healthcare worker who was doing the different technique, the previous technique, had to use a new batch of PPE each and every time. Now, one individual healthcare worker can observe individual patients doing their own swabbing and not need to use nearly so much PPE. That's been a significant advance from a testing standpoint. And so even as we move to expand testing at stand-up sites, swab and send sites, what we've simultaneously seen is that the demand for PPE at those sites is much lower. A good example of that is the testing site that was stood up recently by our colleagues at Holton Regional Hospital. They required very little PPE to do that because for the most part folks were in their car doing the swabbing themselves. So Patty, bottom line, we're continuing to build up our stockpile, but given the spikes we've seen elsewhere, we have more work to do to keep that stockpile robust.
Thanks.
I'm going to turn next to Brad Rogers at GME.
Caught me off guard there. President Trump is now pressuring schools across the country to reopen despite the pandemic. Your thoughts on just how you feel about schools in Maine reopening, and I'm imagine schools in the rural areas, they're probably in pretty good shape. But what about the hotspot areas where there's community spread?
Yep. So Brad, thinking about the rural versus community transmission areas is something we've been thinking about, because it's true that although the baseline number of cases in rural areas is far lower, the rate of new cases is far lower, the impact of COVID-19, if it were to hit one of those areas, would be far greater. And the resource availability of schools in some of those rural areas to contend with that kind of wave of cases, they're more resource limited than other schools. So even as the risk might be lower, the impact that it might have could be commensurately greater. So as we think about opening of schools, we're trying to take those things into account. I know that our colleagues at the Department of Education have been working very closely with schools to make sure that we at the state level are not simply issuing guidance documents that can't be implemented at the local level, both in the status quo or if there were an uptick in cases. We want to provide guidance that's not just protective of human health and student health, but also practical and pragmatic. So we're trying to balance those things. Thus far, I don't think it's an impossible balance. Let me be straight. It's a balance that can be achieved, and that's really what we're aiming for here. I'm going to turn now to Brian Sullivan at WABI.
Thanks, Dr. Shah. I have a couple questions along the lines of what Patty was asking you. We're working on a story here with St. Joseph's Hospital in Bangor. They tell us that they're in preservation mode with some of their PPE, and they're having some of their medical professionals wear their N95 masks for 3 days, up to 3 days, as long as they don't get wet or damaged. So, and also they don't have enough. They say that they don't have enough to test all the people that want to be tested. So could you just talk a little bit about what's going on with some of the hospitals like that in the area? And also, when you talk about the stockpile, how important is it to make sure that there's enough there compared to the people that maybe need it now?
Sure. So Brian, I'll take the second part of the question first. We have not yet had to make that trade-off, which is to say we have not yet been in a position where we need to say, we cannot fulfill this order because we need to preserve PPE for later. As I mentioned, we've now distributed well over 1.8 million pieces of PPE. We've not had to say, sorry, we can't help you, healthcare institution A or long-term care facility B. We've not had to say, we can't help you because we got to save for a rainy day. That's not been our posture. We found that we can simultaneously rebuild our stockpile and fulfill orders at the same time. Now, with respect to what may be going on at some of the hospitals, reuse of, say, N95 masks is something that is allowed by the US CDC. There are good data on the fact that an N95 mask, if properly cared for, can in fact be used for multiple wearings. So there's nothing untoward about that. What we are aware of nationwide is that there continues to be a shortage, not so much of the PPE, as we mentioned with Patty, there's less PPE that's required to do the swabbing. But what is in more of a premium is the swabs themselves. Now, we've been working most notably with a Maine company, Puritan, to make sure that we are able to get swabs in sufficient quantities to test people in Maine. It's obviously our priority. And I really do have to thank our colleagues at Puritan, because when we've asked, they've provided. So we are working to secure an even greater pipeline of swabs so that we can distribute those to healthcare facilities so that more testing can be done. I am going to turn to Joe Lawler at the Press Herald.
Yes, hi, can you hear me?
Yeah, go ahead, Joe.
Okay. I'm happy to report no murder hornets in my house, but so, okay, a few questions here. The one is just a clarifying question. Can you say when the IDEXX partnership will be fully realized and you'll get to the 35,000 tests a week that you talked about earlier? And then my main questions are, what do you think about pooled testing as a strategy of certain populations, maybe teachers, factory workers, et cetera? Do you think that's a good strategy for Maine? And then my other question is, Vermont decided to delay their fall sports to align with the start of the school year so that to buy them some more time. And do you think that from an epidemiological standpoint is a good idea?
Great. So Joe, I'll give you the answer to the first one. I have a clarifying on the second. So as to the IDEX, one clarifier is that the intended maximum throughput with the mobile lab partnership with IDEX is around 25,000 per week, not 35. And we are you asked about sort of when it would be fully actualized. It'll be in stages. So what we're intending to do is start with the first shift, hopefully very soon. We have to, the phase that we are in right now is ensuring that the necessary pieces of laboratory equipment that are needed to stand up additional testing are available. We've been working with manufacturers to obtain those pieces of equipment. Many of you may recall that at the very first briefings, way back in, February, March, we talked about the same challenge. And so we're at that stage. As soon as we started working on the mobile lab, we put in orders. Unfortunately, for some of those pieces of equipment that are needed, delivery of them has not been as speedy as we would have wanted it to be. So that's what we're facing and contending with right now. But as we work our way through that and grapple with it, the way we envision this is that the mobile laboratory would come online in stages. We might start with one shift, then two shifts, and then finally a maximum 3-day or 3-shift model, which would get us that 25,000. And the speed with which we move from 1 to 2 to 3 shifts would really be governed by the demand that we see for testing. So I don't have a firm date. It's really going to be what the testing requires that will drive how we go through the shifts. But right now, our primary focus is getting those remaining pieces of equipment into the lab and calibrated. That's really the limiting step right now. And Joe, on the second question on pooled testing, there are two different, when folks talk about pooled testing, they often are talking about two somewhat different ideas. I want to make sure I answer your question. What are you referring to specifically?
I'm referring to testing groups of samples in batches, and then if they all come back negative, it's clear. If one batch where one comes back positive, then you retest that group.
Yep, good. That's usually the way that I use that term as well, and just wanted to clarify. So thank you. Yes, forget about what I think. The scientific community has endorsed that approach. That is a viable and efficient approach. And then I'm aware that certain healthcare facilities in Maine are already doing so. For example, with preoperative testing patients. So they will pool 4 or so patients, and if one of those comes back positive, then they'll individually test all of them in a separate run. But that is an efficient method. It's been used not just for COVID-19, but for other types of testing as well. And then with respect to Vermont and fall sports, I know that's something that's been under discussion here, Joe. I don't know whether or where folks have landed on that. We at Maine CDC have been involved, as you are probably aware, the sporting component is not distinctly underneath Department of Education. So it's a separate set of conversations that's all obviously interlinked, but I don't know that a final decision has been made on that. I'm going to turn next to John Greenman at WERU.
Thank you, Dr. Shah. I understand that some people with COVID have seemed to recover and then get sick again, sometimes more than once, apparently. And I realize this is uncharted territory and in sort of a state of flux, but is there any more information about whether people are getting reinfected or have never fully recovered? And are they still contagious when they're feeling better?
So, John, the latest data that I'm aware of on this reinfection suggests that it is really more not so much reinfection, but lack of a complete recovery. It's still a scientific mystery as to why some individuals have very few symptoms or no symptoms. Some have mild symptoms, some have profound symptoms, and some have persistent symptoms. That is still a bit of an immunological or scientific mystery, but there doesn't seem to be a lot of great, well-validated data to suggest that, given that we're only about 6 months into the epidemic, that there have been a high number of true reinfections. That is to say, someone fully recovered and then got completely reinfected. Now, I want to be clear. I'm not suggesting that could never happen. There are a number of infectious diseases where just because you had it in January doesn't mean you won't get it again in July, like the common cold or a norovirus infection. Other infectious diseases, we generally know that once you've had it once, you're pretty much covered, like chickenpox. Now, where COVID-19 falls in that spectrum is unclear. It really does depend on whether we're talking about the short term, weeks to months, or the long term, years upon years upon years. Right now, based on the science that's available, it seems to suggest that the immunity that you get from having COVID-19 persists for at least several months. That is to suggest that the reports that are out there of individuals getting reinfected are more likely folks who didn't recover fully and just had COVID come back, even though it was already in their body all along. So much more science is going to be needed on this. It certainly has implications for how we might think of, say, a vaccine and the potential long-term efficacy of a vaccine. So this is precisely, I know, a question that a lot of folks in the immunology community are working on. There are no firm answers, but right now it seems to suggest not reinfection, but rather incomplete recovery.
And I suppose that stands for contagion too, whether or not they're contagious.
You know, the data right now on contagion seems to suggest that after symptoms have resolved, contagion goes down quite significantly. But if someone still has lingering symptoms, the degree to which they could be contagious is not yet well characterized. Mm-hmm. But someone who has completely resolved symptoms, there doesn't seem to be much to suggest that they continue to be contagious, even if the virus might still be deep down inside their body. There's not really a suggestion that they can be contagious. The reason for that is that we always have to keep in mind that having a little bit of the active virus is different from having it in sufficient quantities in your lungs that would allow you to project it and infect others.
All right, thank you. And one quick question from a listener, and it's a summer question actually. If our visitors test positive after leaving our state, I think you've already shown that you probably can't answer this, but if our visitors test positive after leaving our state, how do we find out about that?
Sure. So if someone comes to Maine for an overnight trip from another state, say Pennsylvania, and they then return back to Pennsylvania and are later, a week or two later, diagnosed as having COVID-19, the health department in their home state, in this case, Pennsylvania, in this hypothetical, would be the one charged with undertaking the contact tracing. They would work with our department or directly with individuals who that single case identified in enrolling them in their state's contact tracing. We do the same thing for Maine. If a person in Maine, and we have done this, if a person in Maine has recently reported travel to another state and they come back to Maine and get diagnosed, we reach out to every single individual that they expressed having close contact with. Whether or not that person lives in Arkansas, Alaska, Alabama, or Maine, we're able to contact them in the same way as if they were next door.
Thank you.
You bet. I'm going to turn finally to David Horowitz at ABC 7. David, are you on this afternoon?
Hello?
Yep, go ahead, David.
Hello? Hey, so what advice do you have for people who, other than social distancing, are concerned while they're shopping about other people not wearing masks?
Well, two really important things. The first is they themselves can and should be wearing a face covering. Now, the predominant role of face coverings is to protect other people from you. But there are some early preliminary data to suggest that a face covering can also protect you from other people. I can't stress enough how early, preliminary, and incomplete those data are. But one of the best things that anyone can do is to wear a face covering. Certainly will protect others. And there is some early data, maybe even theoretical data, to suggest it may protect you as well. The second thing that folks can do is try to arrange their shopping schedules at times when the stores are likely to be less crowded. Now, I know how hard that is to do. We all have busy lives, and sometimes we can only go to the store when we can go to the store. But the other thing that can be possible is trying to orient yourself in such a fashion that you're not directly face-to-face with other individuals. It's that face-to-face interaction that can generate the highest likelihood of transmission. So that is, and that's one reason stores have implemented one-way lanes and things of that nature. So trying to orient yourself to such that you're not directly face-to-face with others, or minimizing the likelihood that you need to be face-to-face with someone who's not wearing a face covering, those are all steps that can be taken to reduce the likelihood. And then, of course, on top of all of that is the everyday guidance that folks should be doing, making sure they're washing their hands, avoiding touching their face, things of that nature. All of that, albeit imperfect, can greatly reduce the likelihood of transmission. So thanks for that question, David. Before we wrap up for the day, I'd like to just offer a quick programming note. So I mentioned on Monday, we are evaluating the frequency with which we conduct these briefings on an ongoing basis. And starting next week, we will be moving these briefings to a Tuesday, Thursday schedule. We still want to make sure that we're providing the latest updates, giving our colleagues in the media an opportunity to ask questions that we know are on everyone's mind. So starting next week, we'll be moving these briefings to a Tuesday, Thursday schedule, keeping the 2 o'clock time window. So what that means is that we won't be with you this week, but I will look forward to joining everyone next Tuesday, July 14th at 2 p.m. for the next update on COVID-19 in the state. So with that, I'd like to thank everyone for taking some time out of their day to join us. I hope everyone has a great day. As always, please be kind and take care of one another. We'll talk again next week.
Thanks, Dr. Shah.